Good afternoon all. Thank you, sir. Today I'll be talking about double diabetes in young. Before going to the details of double diabetes, I would like to highlight an interesting case study here. We have in 2014 we have a 6-year-old child diagnosed with type 1 diabetes. She had tested positive for GAD antibody and the C-peptide was absent. And her weight was normal and her HbA1c was 9.7%. The only thing which was not is she had a family history of type 2 diabetes in both her parents. We come across this sort of presentation often in our clinical practice. The same child was started on insulin and been continuing insulin for the past 11 years. Presently in 2025, her present age is 17 years. She has developed obesity. Her BMI is 30.9 and features of acanthosis nigricans. Our daily insulin dose recommended is about 86 units, which is more for her weight, and her HbA1c is 9.6%. Often we come across this clinical picture in type 1 diabetic children or individuals in our setup. So here a type 1 diabetic child has developed features of type 2 diabetes, that is obesity and insulin resistance over a period of time. So with this information, let's try to understand what double diabetes exactly is. So this term was coined in 1991, and double diabetes mainly refers to individuals with type 1 diabetes with overweight, with family history of type 2 diabetes, and with clinical features of insulin resistance. It is also called by mixed type diabetes or hybrid diabetes. So this bar diagram clearly shows the increased prevalence of obesity and overweight over the past decades in type 1 diabetic individuals. We can see the prevalence of obesity as well as the overweight is on the rise. Almost 20 to 25% of type 1 diabetic individuals are overweight and 5 to 10% of them are obese. We have seen clearly that double diabetes demonstrates both the symptoms of type 1 and type 2 diabetes. So what may be the theory behind this? There are two theories to explain this. One is insulin resistance accelerates the autoimmunity in healthy genetically predisposed individuals, augmenting beta cell destruction, leading to type 1 diabetes. The other pathway is the insulin resistance can directly trigger autoimmunity, leading to beta cell destruction and type 1 diabetes. We can see the common factors in both the pathways is insulin resistance and autoimmunity, which may be the hallmark of double diabetes. So who are at risk of developing double diabetes? So genetic predisposition really plays a role. People with HLA haplotypes on chromosome 6 are at increased risk of developing both type 1 and type 2 diabetes, and they may develop double diabetes. And so are individuals with strong family history in their first degree relatives. When it comes to obesity, mainly insulin resistance, central adiposity plays an important role in individuals developing double diabetes. And again, type 1 individuals who are diagnosed and treated with high doses of insulin gain weight, and this leads to insulin resistance and may end up with double diabetes. Again, sedentary lifestyle and diet plays an important role in developing obesity and insulin resistance, leading as a risk factor to double diabetes. And this S.Uthra hypothesis, which is beta cell destruction with hyperinsulinemia secondary to autoimmunity and insulin resistance, is a risk factor for developing double diabetes. This image shows the clinical features of type 1 diabetes demonstrated by the orange hexagons, and type 2 diabetes by the blue hexagons, and we have the double diabetic clinical features on the bottom hexagons. So we all know that clinical features of type 1 diabetes are osmotic changes like polyuria, polydipsia, weight loss, and mainly autoantibodies. Whereas when it comes to type 2 diabetic clinical features, they are mainly increased BMI, dyslipidemia, hypertension, and increased cardiovascular risk, probably most of metabolic syndrome. But when it comes to double diabetes clinical features, it combines the clinical features of both type 1 and type 2 diabetes, mainly beta cell autoimmunity, obesity, insulin resistance, and they have family history of type 1 or type 2 diabetes. They are prone for ketoacidosis, and they require insulin from the onset of disease. So what are the key criteria for the diagnosis of double diabetes? The individual should be diagnosed with type 1 diabetes, they should have family history of type 2 diabetes, and they should have overweight or metabolic syndrome features, and they should have clinical features of insulin resistance, especially EGDR, which is the glucosal disposal rate. It indicates, the lower it is, it indicates the insulin resistance. If EGDR is less than 8, it indicates it's a clear-cut diagnostic criteria for double diabetes. So what are the markers or clues we have to look in for double diabetes in type 2 diabetic individuals? We have to look for central obesity in type 1 individual, hypertension, hypertriglyceridemia, low HDL levels, elevated liver enzymes, and polycystic ovarian disease. So, coming to complications, double diabetes individuals are at high risk of developing complications like type 1 individuals as well as type 2 individuals. The prevalence of microvascular complications like diabetic retinopathy, PDR, microalbuminuria and macroalbuminuria are high in double diabetes individuals when compared to the type 1 diabetic individuals. The same when the prevalence of macrovascular complications is also high in double diabetes individuals when compared to the type 1 individuals. We can see the increase of coronary artery disease, MI stroke, peripheral artery disease, and diabetic foot prevalence more in double diabetes individuals when compared to the type 1 individuals. So when it comes to management of double diabetes, the key feature is to have a healthy lifestyle. This includes healthy diet, that is with balanced macronutrient intake, with proper portion control, high fiber rich foods, proper hydration, with proper meal timing and frequency. Regular exercise, almost 150 minutes a week, according to WHO, maintains a healthy weight in addition to improving cardiovascular fitness and glucose metabolism. Psychological and behavioral therapy should be given to monitor and maintain their health, eating habits, the physical activity, their glucose monitoring, as well as their insulin techniques, and care should be taken to see whether they are able to cope up with their emotional stress like anxiety or depression secondary to peer pressure. So, insulin is the mainstay of management in double diabetes. So, individuals with double diabetes should be started on individualized basal bolus regimen. They may require more frequent dose adjustments due to insulin resistance and during the time of puberty. We should always aim for a stable glycemic control. At the same time, we should see that the weight gain is minimized, and we can also consider using continuous glucose monitoring as well as insulin therapy, and with the use of smart pens, we can achieve a better glycemic control and improve their quality of life with better flexibility. So when it comes to oral anti-diabetic agents, metformin can be added on top of insulin to improve the insulin sensitivity. The roles of SGLT2 inhibitors and GLP-1 receptor agonists are not yet proven. Clinical trials are ongoing. Again, individuals with double diabetes should be monitored and screened for dyslipidemia, microalbuminuria, and hypertension, and if necessary, statins and antihypertensives can be initiated to prevent cardiometabolic risk. So coming to the takeaway messages, we know double diabetes is characterized by the presence of features of type 1 and type 2 diabetes in the same individual. It is also called as mixed or hybrid diabetes, and WHO has accepted this as a type of diabetes. Factors contributing are mainly genetic predisposition, obesity, sedentary lifestyle, and insulin resistance. Strategies to prevent or mitigate the development of DD include maintaining a healthy weight with proper diet and regular physical activity. And these double diabetic individuals are at high risk of developing microvascular and macrovascular complications. So what are diagnostic criteria for double diabetes include individuals with type 1 diabetes, with family history of type 2 diabetes, with overweight, metabolic syndrome, and insulin resistance, especially EGDR below 8. Achieving stable blood sugar levels can be more challenging in double diabetes due to its dual mechanism of insulin deficiency and resistance. Hence, insulin is the mainstay, metformin can be added. Managing double diabetes often involves intensive lifestyle interventions in addition to pharmacotherapy. Further research is essential in this high-risk population to document health risks and to develop effective long-term treatments tailored to their specific needs. Thank you.